There are two factors to consider. One is that COPD is greatly underdiagnosed condition right now. The reason probably is because not enough screening is done, which depends on doing a spirometry or breathing test. In advanced world, the most common cause of COPD is smoking. Unfortunately, there are some headways made, but there's still millions of people are at risk for having it. In other countries, conditions such as use of firewood, etc., are a major contributor. There are differences inherently in how people get COPD. In other words, some people are more susceptible than others genetically to that. Aging also enhances that. And in terms of treatment, it's somewhat undertreated too, because many people get used to their shortness of breath and consider that to be a normal part of aging, and therefore don't seek treatment. And some modalities of treatment, such as pulmonary rehabilitation, is not offered so readily. Therefore, there is work to be done. One is people get used to the way they are. Patients do not complain about their symptoms, which are basically shortness of breath, especially shortness of breath with exertion, and sometimes cough. And on part of physicians, most physicians do not consider it to be, unless the patient starts huff and puff and basically turns blue in front of them, do not consider it to be a possibility, or they don't suspect it. That's why more screening is needed. These patients, especially as they age, or if they have a history of smoking or being exposed to inhalations or being exposed to fumes and industrial exposure, need to be periodically, like once a year or even more, getting a spirometry to establish a diagnosis. There is a tendency for that to improve, especially with some global initiatives that are now spearheaded by World Health Organization, and so that increases education among physicians. We also need to increase public education. You should not basically put up with your shortness of breath when you climb stairs and consider that to be normal. You're talking about two phenomena here that kind of coalesce. Aging creates a COPD-like pathology in the lung, because the lung tissue becomes more pliant and therefore more collapsible. I shouldn't call it pathology, but a change, because it's normal. On the other hand, the smoking obviously is a direct producer and initiator of COPD. That said, because people are different in how they react to that, some people can smoke for years and don't have much of it, and some have a lot of it. But overall, the number of patients with COPD is increasing. In fact, it's assumed that death from COPD, unfortunately, is going to move within this period of time from 4th common cause of death to 3rd common cause of death in the United States. One modality that has been available for a long time but is more commonly used now is use of pulmonary rehabilitation, that offers a significant improvement in quality of life, and probably some improvement in longevity. Otherwise, the smoking cessation plays a major role in it. Avoidance of infections or exacerbations, because each exacerbation, while you recover from it, but you really may not go back to the first place you were. So these are all improvements. A lot of work is being done in identifying the phenotypes of COPD and genetic factors on that, and hopefully we are going to have medication treatments that in each single patient identifies the defect and address it directly. That would include specific anti-inflammation or anti-inflammatory agents, because a portion of COPD, at least in some patients, is a neutrophil-induced inflammation. The opioids play a role in that they basically blunt the sensation of shortness of breath, which is a disabling factor, and it matters in terms of quality of life. One has to be, however, careful, because they also make the blood gases worse, and kind of in that respect have an impact on that. But I would say it's a fine assessment of risk and benefit, especially in patients whose COPD is more emphysema, and shortness of breath is very disabling, but blood gases are not that bad. It may become a viable option in terms of blunting their symptoms. It does not treat COPD per se.